sir. Dr. Manjunath is here with us. Please give a large round of applause. Kindly join us on the stage, sir. Dr. Manjunath is Professor of Cardiology and Director, Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. Please join in Mr. Riyad Matthew. He is a Chief Associate Editor and Director, Malayalam Manorama and The Week. And Mr. Matthew T. George, Senior Associate News Editor. Thank you, gentlemen. May I request Mr. Matthew T. George to kindly give the welcome speech. Thank you.
Thank you, Pooja. Apologies for the delay this morning, and quick word of welcome to everybody. When the week stepped into its 30th year in 2012, we marked it with a health conclave in Delhi. 2 amazing days filled with insights from the medical field. Many observations from those days have remained with me, but perhaps the most impressive one was the one made by Dr. Gaurav Gupta, currently Director of Endovascular and Cerebrovascular Neurosurgery at Rutgers Robert Wood Johnson Medical School. Somebody in the crowd asked him, why does a surgeon decide to operate? Dr. Gupta's answer was more philosophical and spiritual than medical. He said, the human body is a temple. You don't go in because you can. You go in only when you must. A meditative silence fell over the crowd. I would like to think that the laymen in the crowd were meditating over their own status as homes for the divine, while the doctors present were thinking about their own sacred status as high priests who are privileged to meet the divine day after day all their lives. The Week Best Hospitals Award is a natural progression of our constant and continued interest in the sector. We started the survey in 2004, and it has grown into the most respected hospital survey in the country, covering 17 cities plus the National Capital Region. And in the process, we talked to almost 800 general physicians and 1,200 specialists. This year marks the end of the survey's 10 years. 2024 will see the 20th edition of the Week Best Hospitals Special. The week also comes often with a free supplement named Health to all buyers of the week. No other magazine in the country does that. A free supplement goes out at a considerable cost, but our editor, Mr. Philip Matthew, believes that a reader would appreciate non-biased and actionable advice about health and wellness. His view does not surprise me because his grandfather was a doctor in the Madras Presidency Service who spent most of his career caring for rural communities. Mr. Philip Matthew got his first name, in fact, from this doctor grandfather who was trained at what is now the Stanley Medical College in Chennai. I know you'd rather listen to the eminent speakers listed for the day, so let me do my duty quickly. On behalf of the week and all of you gathered here today, it is my pleasure to welcome the Honorable Chief Minister of Karnataka, Mr. Siddaramaiah, in his absence. It is a packed day for him, like any other day, and it's an engagement in Mysuru soon after this. His commitment to quality healthcare is evident from 2 recent efforts by his ministry: the Anemia Mukta Paustika Karnataka Action Plan and the flagging off of 262 ambulances to support trauma care and to extend medical services to rural Karnataka. I thank the Chief Minister for making time for us and agreeing to honor our awardees. Thank you, sir, and welcome. The Honorable State Minister of Health, Mr. Dinesh Gundurao, is also being welcomed in his absence. In fact, the Chief Minister and the Honorable Health Minister are together at an official event as we speak. Mr. Dinesh Gundurao has lately been in the news, among other things, for his resolve to take on the sex determination racket in the state. Thank you, sir, for making time for us. We extend you a warm welcome. I would also like to quickly welcome our keynote speaker, Dr. Manjunath, Director of Sri Jayadeva Institute of Cardiovascular Sciences and Research. I read the words of praise that the Chief Minister had shared about your institution, sir. Congratulations and welcome. Mr. Riyad Matthew, Chief Associate Editor and Director of the Week, is a powerhouse who lives out of a suitcase for half the year. Yesterday Delhi, today Bengaluru, today evening Kochi. Thank you, Riyad, for being here. Welcome. My warm welcome to our 4 panelists: Dr. H. Sudarshan Ballal, Chairman, Manipal Hospitals; Dr. B.S. Srinath, Managing Trustee, Sri Shankara Cancer Foundation, Bengaluru. Dr. Santosh Shetty, CEO, Kokilaben Dhirubhai Ambani Hospitals, Mumbai. Dr. Sajan Nair, CEO, Zydus Hospitals, Mumbai. A warm welcome to you, Dr. Ballal, Dr. Srinath, Dr. Shetty, and Dr. Nair. A quick word of welcome also to Professor K.K. Verma, Dean, AIIMS Delhi. Dr. Prasanna, President, Federation of Private Hospitals and Nursing Homes Association of India. Dr. Govindaya Yatish, President, Private Hospitals and Nursing Homes Association, Karnataka. I extend a warm welcome also to Mr. Anthony Prashant, Senior Partner, Deloitte, who is here to speak on AI in healthcare. Welcome, Mr. Prashant. Because of the paucity of time, kindly forgive me for not welcoming by name all doctors from our body hospitals and well-wishers gathered here. Thank you for making time in busy Bangalore to be with us. Welcome. I also welcome all my colleagues from the Malayalam Manorama and the Week. A warm welcome to you all. Have a wonderful day. Thank you.
Thank you, Matthew. May I request for a bouquet to be given to Dr. Manjunath, please? And may I please request Dr. Manjunath to kindly share his insights with us and come and deliver the address.
Dear colleagues and CEOs of many hospitals, and also the dignitaries in chair, I'm very thankful to the week for this invitation to amongst you for this health event to deliver this keynote address. See, actually in this digital age, the medical landscape has changed significantly, and our theme is to provide a quality care to cross-section of the society at an affordable cost. So that is the need of the hour. The excellence, of course, the week is doing a great job. In fact, they are touching the hearts of the hospitals, and by publishing the rankings of hospitals in various categories and various streams, and that is a sort of a good feeling that if your hospital is appearing in the list of some of the top ranking hospital, it really is a satisfying thing. So in fact, in this audience there are many rank holders as far as hospital administration is concerned. My hearty congratulations to all those distinguished hospitals. See, excellence is never an accident. Excellence is never an accident. It's all can happen because of high intentions, sincere efforts, and also intelligent execution. So that's what it has happened. If you look at the healthcare scenario in India, see, on one side we are looking at the clinical services. On the other side, we are looking at the medical education. Always we think about, suppose you look at medical education side, there are nearly 768 medical colleges in India today. There is a sudden jump in the number of medical colleges in the last 4 or 5 years. So annually, the MBBS intake is somewhere around 1,10,000 seats, and very close to that, we have around 80,000 postgraduate seats. See, what are we looking today? Today, yes, there is a national entrance level examination for these courses, and unfortunately, the qualifying marks has been reduced to 0, and it has gone even below 0 also for negative marking. So are we justified in conducting NEET examinations anymore? So what we are looking at, are you just looking at the number of doctors, or are you looking at the quality of doctors? So in my opinion, it's the quality that it matters most. So because otherwise, if there is mushrooming of these colleges, I agree there is a maldistribution of medical colleges. About 40% of population lives in southern India, including Maharashtra, where 60% of medical colleges exist. And 60% of the population lives in North India and Eastern India, where 40% of the medical colleges exist. So as far as number of doctors are concerned, India, as we all know, India is a country in diversity. So we have this diversity even in our healthcare system. In southern India, certainly healthcare system is far, far superior compared to the north. So we see the healthcare system is in diversity. Today, you look at the number of doctors available, or number of beds available. 70% of the care is still given by the private sector, and 30% of care is given by the government institutions. If you go further, as far as tertiary care is involved, 90% is delivered by the private healthcare system, and only 10% is given by the public hospital. I am coming from a public hospital called Jayadeva Institute of Cardiovascular Science. This is an exception, because only as far as Karnataka is concerned, 45% of the cardiac care is given by a public institution, Jayadeva Institute of Cardiovascular Sciences. We have close to 2,000 cardiac beds. We have 125 cardiologists, 60 cardiac surgeons, and about 50 cardiac anesthetists. This is let alone. I mean, this cannot be taken as a uniform example across the country. So, need of the hour, yes, we need more doctors, but we need well-trained doctors, well-educated doctors. Otherwise, what is happening, if you are reducing the cutoff marks to 0, NEET examination cutoff point to 0, then we are going to produce more and more number of half-baked, undercooked, untrained doctors who are more harmful to the system than leaving them alone. Going by the statistics today, yes, we always talk about the health expenditure. Unfortunately, despite repeated attempts, repeated representations to the government, the health expenditure is only 2.1% of the GDP. You look at other countries, the global average of GDP spent on health is somewhere around 9%. But as far as India is concerned, it's only 2.1%. And that is where one has public as well as private, it is not going beyond 3.5% of the GDP. Take countries like France, Canada, Japan, even our own neighboring nation, Sri Lanka, they are spending more on the healthcare expenditure. That is also an important. Then where are we as far as the healthcare professional numbers are concerned? India today has close to about 13 lakhs allopathic doctors and about 5.6 lakhs Ayush doctors. So if you look at this, in southern states, the WHO says there has to be one doctor for about 800 population, but in southern state we have one doctor for 450 population. So we are well above the WHO. But certainly there is a maldistribution. More doctors are in the urban and less doctors in the semi-urban and rural areas. So here comes a policy decision why doctors are ready to go to the semi-urban and rural hospital, but the problem is there is no safety and security and there is no conducive working atmosphere for the doctors. See, we are sitting in big city, tier 1 city, we are well protected, well guarded, but there what is happening, the doctors in the rural area, they are facing a lot of problems. There is a verbal assault, there is a physical assault, even not just even take nursing homes, even in the tier 2 and tier 3 in protest, they demand money also from the hospital establishment to take over these bodies. So I think we need to create an excellent working atmosphere. There has to be a safety. And of course, this is a government policy actually. Now what is happening, the public hospitals in districts and taluk, maybe because primary health center, and primary health center and also the community health center still the cornerstone of our health system. They need to be strengthened. And today what is happening, all these things are coming under Jilla Parishad, which is governed by a locally elected body. One has to take away the control of this hospital out of this local body, Jilla Parishad. Then they should come under a separate directorate of health. Then we'll have, because today doctors are, you go to any medical colleges, 60% are ladies, 40% are male doctors. So where is the security and safety for the doctor? They are ready to work in rural areas, semi-urban areas. That is one. Another thing is, you look at the bed ratio. Again, there is a diversity in bed ratio. The WHO says there has to be 3.5 beds for 1,000 population. 3.5 beds for 1,000 population. But southern India, we have 4.5 beds for 1,000 population. But you go north, it is 0.92 or maybe one bed for every 1,000 population. So this is where this maldistribution need to be corrected and addressed. Another important thing that is happening in the public health sector, what is happening? We are coming with buildings. We are coming with talking about infrastructure. The need of the hour is to strengthen the existing system with more manpower in terms of doctors, nurses, technicians, and there has to be a very good mechanism. There has to be a very good mechanism to run this system, and there has to be, see, I think equipment alone, building alone cannot give a treatment. There has to be a very good working atmosphere in that. There has to be some amount of decentralization and delegation of power. Unfortunately, doctors are branded as worst administrators. Doctors are branded, of course, we have exceptions here. We have Dr. Ballard, we have Dr. Srinath, and of course, there are so many here. Because doctors are also considered as a soft targets for everything. If anything and everything that is happening, doctors are, because basically we are soft in our heart, soft in our, and we are scared, that sort of a thing. So this is where probably we have to, most important, our theme should move from construction to creation of post. And there has to be a very fast tracking mechanism to recruit doctors without any hassle, and it has to be an evolving process. You go to many hospitals, recruitment, what is happening, the recruitment process itself takes 1 year. Then some will join, some will leave, and we need to really prevent brain drain from this hospital. Only way we can prevent brain drain from the public hospital is you have to create quick, there has to be some promotions, on-time promotion, and you have to incentivize. Unless you incentivize and there has to be a separate pay scale for both the broader specialty and the tertiary care specialties in a government sector, public sector. That's what is happening, that is how. Then 65% of deaths in India today is due to non-communicable diseases, as you all know. I need not tell that. 30% of deaths in India is due to heart attack and cardiovascular disease, 30%. As a result, the need of the hour is to take this treatment to the doorsteps of the patients, what is called hub and spoke model. We need to really embark on this hub and spoke model for treating cardiac emergence with heart attack or even for brain stroke. Today, ischemic brain stroke has to be treated exactly like a heart attack. And so this is where we need to really strengthen our emergency services or the golden hour services in the semi-urban and rural area and hub and spoke model. And the hub will be both tertiary care public hospital and private hospital, because public hospital alone cannot take care of this. So they have to be connected. So we have to, in fact, this hub and spoke model can really save lives and can deliver the treatment. The spoke hospital will be tier 2, tier 3 cities, or maybe primary health center or a taluk hospital, So now using this technology, nowadays you can connect easily, and there has to be an agency to monitor, supervise and coordinate all these things between hub and spoke model. It should be taken forward for both heart attack as well as ischemic stroke model. Another important area is, we are talking, of course, the best health indicators are even today is infant mortality or maternal mortality. Yes, it is coming down. Certainly it is coming down, but still we have to get into the single digit. For this, neonatal care need to be strengthened, because the real the pocket pinchers is basically when there is some emergencies. So we need to strengthen the critical care management in district hospitals and taluk hospitals. That is actually can save a lot of, that is where they, in fact today, most of the emergencies, 90% of the emergencies are treated in the private sector, because, and we need to build up a excellent system there. Then coming to Ayushman Bharat scheme, there are states who have taken Ayushman Bharat scheme. There are some states who have not taken Ayushman Bharat scheme, but there is, in my opinion, although they say it is an universal health scheme, it is not an universal health scheme, and probably because this was introduced in the year 2018, and many procedures are not included or not coded in Ayushman Bharat scheme, and the package rates are not even meeting the actuals. Here is a system, yes, it's good intention, it has been introduced, but certainly one has to revisit and you have to revise the package rates. Otherwise, what is happening, most of the beneficiaries are coming and crowding the tertiary care government hospital, overcrowding. As you know, when once that is, at least 30-40% of these patients should be shifted to a private care, private hospitals. Only way private hospitals can take this is, you have, for example, I will tell you, double valve replacement will actual cost I am talking about, cost 2.5 lakhs. But the scheme provides 1.75 lakhs. For doing one double valve replacement heart surgery, we lose about 75 to 80,000. And cost of the tissue valve, cheapest one, is not for one individual patient, it is for the entire family. So many expensive procedures are kept out of this Ayushman Bharat scheme. So it has to be properly revisited. They have to revise the package rates. And see, nobody is asking for a huge profit. At least it should be, at least it should meet the actuals. Then we can work on a volume cum revenue model. What is volume cum revenue model? If you start treating more and more number of patients, even at a reasonable cost, ultimately some revenue can be generated. So volume cum revenue model can happen. So Ayushman Bharat scheme, in my opinion, does not cover all procedures, and whatever procedures they have covered, the rates are phenomenally low, because now dollar rate has gone up and consumables have gone up. So now, as a result, there is a burnout syndrome happening in public hospitals for the doctors, nurses, even in the periphery. One doctor sees 150 outpatients. In what way it can happen? So the need of the hour, we have to strengthen the existing public healthcare system with quick recruitment. We have to strengthen them with more manpower. Human resources is very, very important. Then, in fact, in my opinion, one of the best healthcare systems supporting this poor patient care is in Orissa. They have their own state health scheme, not connected with the Ayushman Bharat scheme. They are spending 2,450 crores on the health scheme for the poor patients. And the coverage is up to 5 lakhs for an individual patient. In Ayushman Bharat, it is for the family. And there are a lot of problems. If a patient requires a second procedure within the 6 months of first procedure, you are not getting, they are not reducing the package rate by another 50%, which is already, the first package rate itself is precariously low. So, for example, take government of Karnataka. They are spending 950 crores on this so-called Ayushman Bharat and Arogya Karnataka scheme. and it is a bigger state than Orissa. Orissa is spending 2,450. I think this is where a proper thought process has to go, and we have to, then only the quality can improve. See, otherwise, if there is a overcrowding of the tertiary care, public hospital, quality will suffer and mortality will go up, and the system goes awry. Then, wherever there is possible, at least in tier 2 and tier 3 cities, wherever it is possible, one can always embark on the idea of public-private partnership models. So for that, there has to be a very quick mechanism, and if some entrepreneur is coming up, one has to, they can always, the land can be granted at a reasonable rate. Then particularly in tier 2 and tier 3 cities, we need many well-managed, well-equipped, well-monitored, well-supervised super specialty or multi-specialty hospital. This is also another important thing. And another important thing I wanted to emphasize, 13% of deaths in India is due to accidents. Very unfortunate. 13% of deaths in India is due to accidents. After heart, cardiovascular disease mortality is, in fact, it is more, mortality out of accidents is more than cancer and respiratory illnesses. So that is what is happening. Of course, we don't wish these accidents should happen. We are very sorry about that. There has to multidisciplinary departments has to take care, road safety measures and all those things. But organ donation, the organ transplantation is one area where it has to be strengthened. There has to be a more awareness program. There has to be a nodal, there has to be a nodal, regional nodal agency to see that organ donation can move it forward. That is one of the important thing, because India is also one of the best destination for health tourism. Of course, health tourism is more into the private sector, because of course for 3 reasons. Number one, we provide a very good quality care. We have a great talent pool of health care professionals, and it is certainly cost effective compared to other countries. That is also there, and connectivity is also fine, and it is also an English speaking country also. So all these things, health tourism is also another important thing what we are looking at. So certainly this is my feeling actually. Even a private hospitals also should have some sort of a CSR. Of course, there are like Srinath and all, they are doing great CSR activity. So at least 10% of their beds, 10% of their beds need to be kept for treating the lower middle class at the government rate. Of course, I can't tell everything. Probably that could be taken, because always a volume cum revenue model can kept, because the ICU care as well as the other tertiary care, at least if at least hospital which has a bed strength of more than 50 can keep 10% of their beds for the poor and the middle class people, where these things can happen. Certainly CSR activity also can be a part of our corporate hospital. This is how we can make this particular thing. Then today we have this artificial intelligence, and we have this machine learning and deep learning, and all those things are there. So we can integrate all these technologies and reach your less accessible area and bring them under a very good monitored care. So for example, one of the problem we face in tier 2 or tier 3 cities is investigations. Today we have AI based laboratories, so they can have a quick tests, and also interpretations can be done. So we have to integrate this artificial intelligence as well as our technology for providing maybe a tele services. Of course, tele ICU services can be provided on a hub and spoke model, and we can improve the healthcare system. Then a word about transfer policy. I think this is where there has to be a very good communication mechanism. Very sick patients, many untreatable patients, this is the onus on the hospital and the onus on the doctors. Many a time we see 20 days old baby shifted by an ambulance from 500 kilometers cities without understanding it's a treatable disease or not. I think one of the recent episode has happened in Nimans. See, before shifting a very sick case from one hospital to a destination hospital, it is the duty and the responsibility of the doctor in that hospital exchange the medical reports initially with the destination hospital and see whether it is treatable or not. Otherwise, what is happening, there is some system, ambulance system, they create a sensation, and also they create, along with the media, they create a green corridor, and then they reach and the patients, attenders have to pay hefty amount to the ambulance. When they come here, it is untreatable disease. Then after coming here, they die within few hours or few minutes, then entire system gets a bad thing. I think there has to be a very good transfer policy for shifting the sick patients. This is where, despite our best efforts, our profession is getting a bad name. So this is where we are helpless. Suppose many a time they are end stage heart failure, end stage neurological problem, end stage cancer, or patients in gasping situation. So unnecessarily some hospitals, I can say it is an irresponsible shifting of their responsibilities to the destination hospital. This is how the system works. So definitely we need to, so the two important things is it's not the number of colleges or number of doctors that are important. We have to produce quality doctors with a better, then of course another important area is nursing colleges. See, today what is happening, there are about 33 lakhs qualified nurses in our country. We need more staff nurses. Certainly we need more staff nurses, but problem is we need well-trained staff nurses. Nearly 50 to 55% of nursing colleges in this country do not have their own hospitals. Then where is the question of training? I mean they just have a certificate. So we need to provide a quality care and a quality education, and also we have to work together in tandem, public hospitals and the private, and certainly the government sponsored health scheme need to be strengthened, need to be revised, otherwise it's not possible to provide a quality care. So with this, certainly today, yes, we are in an era of digital technology. All of us are under stress. We are facing two syndromes actually, particularly in tier 1 cities, what is called idiot syndrome. Idiot syndrome is nothing but internet-derived information obstructing treatment. Internet-derived information obstructing treatment, my God, how many times. So in fact today, so-called sophisticatedly educated people, they don't get a proper treatment wherever they go. They confuse, they dictate that this is the way you have to treat and all. In fact, less ignorant people get a very good treatment. Then another important syndrome is CAPI syndrome, children abroad, parents in India. Children abroad, parents in India, that is another group which is creating problem for all of us. So certainly the healthcare system has really moved forward in this country, and in fact Indian healthcare system is best appreciated by NRIs visiting us, because everything, even walk-in patient get all procedures done, investigations done, but our own people always are very hesitant and very reluctant to appreciate our healthcare services. So certainly the longevity as touching 70, it is all because of both private sector and the public sector contributions, but we need a lot to do. And just again I emphasize, we need to really, particularly public sector, we have to reinforce the existing healthcare system with more manpower, with better, conducive administrative measures. That is the way forward. Thank you very much.
Thank you, sir. May I request Mr. Riyad Matthew to kindly hand over the salvo to Dr. Manjunath, please. Thank you, gentlemen. Kindly join us in the audience. May I now request Mr. Anthony Prashant, Senior Partner, Deloitte, to kindly speak on artificial intelligence in healthcare. Thank you.
Morning, and it's very proud to be amidst eminent people from the industry. And whenever I give such when I speak on such topics, my first points are words of gratitude to this community, especially because this was the community that helped us or helped the country when we went through the crisis during the pandemic. And while people were saying that we will go through a new normal, we still were able to maintain the old normal. So maybe a round of applause to all of us. Biology is a subject which I dreaded in my school days. I'm an engineer by profession, but the irony is that I lead the life sciences and healthcare consulting practice for Deloitte. So that's why I'm starting with that disclaimer rather. So I'm here to talk about how AI and advanced analytics is going to shape the sector. And as Dr. Manjunath mentioned, it is an important element for us to address some of the biggest priorities of the healthcare industry in India. We are all aiming towards how do we improve population health, which means accessibility. You know, when Dr. Manjunath spoke about the diversity in the spread of infrastructure between north and south and the disparity that we see. So how do we therefore still ensure accessibility and improved health for our population? And second is the quality of care. How do we enhance the quality of care? And finally, how do we do this at a reduced cost, therefore making healthcare affordable to all the population in our country? So what is AI? There are many definitions for this. And one definition which really intrigued me was, it stated that it's a field of computing where intelligent machines ethically augment human cognitive capabilities and experience. And which is true, and that is what we are witnessing today. For example, 25 years before, when all of us took a flight to travel from one place to another, look at the tickets that you had. It was like a book, some 5-6 pages. It was printed and given to you, and we take it to the airport. Even while entering, we show that to the security there. But then later, what happened? From a book, it came to a piece of paper. We can actually print out a piece of paper and then take it to the airport. And then we moved ahead. We don't need a paper. We went into paperless. We started showing it on our mobile phones. Today, we don't even show our mobile phones. We just walk into the airport using DigiYatra. AI recognizes your face and then you let in. So that's the transformation that we have come in from. And that's what exactly AI will also be helping or enabling the healthcare industry in our globally as well as in our country. Today, if you look at how 5G has come in the last 1 year, we had 100 million subscribers, and also 50% of smartphone users are on 5G. Now, what is this going to do to us? Therefore, people equipped now with more more data, and more computing power are going to demand more. So what is the consumer of the future going to look like? And when I meant consumer here, consumer of healthcare services. How is he going to look like in the future? He is going to exert pressure on this ecosystem. He will demand more tailored, personalized, and more predictive kind of treatments. And he will also demand health outcomes which are backed by AI. And how is this going to happen? Let's look at the care pathways or a typical patient journey, right from preventive to diagnosis to treatment and post-adherence. All of us have smartwatches today, right? Everybody has more, I assume at least 60-70% of people in this room will have a smartwatch. So today, our vitals are being monitored, self-monitored. We look at our vitals, we assess on our own, and then we try to take some actions based on it. Tomorrow, that is going to change. It will start giving you instructions on routines that you have to follow, what work activity you need to do, what are the workouts. It will start connecting you to a care provider automatically and tell you you're going to have a potential problem, and then therefore you need to speak to someone. So that's preventive healthcare. And even when it goes to diagnosis, today we still have BP monitors at home, we have SpO2 meters at home, we monitor it. Tomorrow, people are talking about implants inside an individual, which will actually monitor your vitals on a day-to-day basis, and it will automatically diagnose for any potential disruption. And more importantly, we may not even visit a diagnostic lab. Today we have portable medical devices which your diagnosis may happen at home. So therefore, these are changes that may happen in the patient journey. And then when you get into treatment, today we all use apps also to book an appointment with a doctor. We try to choose a physician who based on ratings, etc. But tomorrow even that will move away, where the moment your medical device at home senses a problem, it's automatically going to book an appointment. It's going to look at your schedule. It may even book it may automatically book a cab for you to travel to a place, and you may even get a treatment. You may be operated surgically through a robot where the surgeon may be 50-60 kilometers away from you. So that's the kind of change that we are expecting in the patient of the future. So the patient of the future will be well-being focused. He will have access to multiple information, where Dr. Manjunath said adroit. So we will have to cope with that. And he will also be dependent on AI-based outcomes, and he is going to demand for the same. So what does this mean if the patient of the healthcare is going to be much empowered and equipped? How is this going to disrupt the healthcare ecosystem in the future? And we are seeing some 4-5 trends. One is individuals will be incentivized for taking care of the health. And we have seen this. There is an insurance company which gives their customers with a smartwatch, and they monitor the individual's, let's say, the activities, number of steps. So if he does, let's say, X number of steps this month, his premium reduces the subsequent month. So individuals are getting incentivized for taking care of their health. And therefore that all of us needs to ask about. The third disruption we are also seeing is, but tomorrow he'll also be equipped with AI. He may even start doing consultation. In medicines, a patient can be monitored remotely. For example, I was reading the magazine, the Week magazine. There's a doctor who says, the moment you send an image of your eye, we will tell you whether you have a diabetic retinopathy, which is the disease which is there or not, or 10 years or 20 years down the line when you will be affected with that disease. So you just send a picture of the eye, you may not even visit the hospital. Dermatology, you may scan your skin and then send it to, upload it on an AI model. It will tell you what is the what is the reason, why is this particular rash is attempting, and what medication. So what will typically happen is, this will reduce a patient entering or re-entering a hospital. It will reduce a patient entering or re-entering a hospital or any medical phase. So AI can, that's an so in outpatient care, that's a disruption that may occur. And more importantly, remote monitoring. Even after treatment, when you post-treatment in remote monitoring, today there is an organization in India which does dialysis at home. The entire dialysis is done at home, so the patient is monitored through a command center. All the equipments are monitored through a command center. AI runs predictive models on the vitals of the patients and predicts if this person may go in for a cardiac arrest maybe 2 days down the line or maybe in the next 6 hours. It also predicts the equipment maintenance and status so that it triggers another model for maintaining the medical equipment also. But this changes completely the business model. If you are doing remote monitoring, then the new business model erupts is, how are you, in case of emergencies, how are you going to ensure a physician lands up at that individual's house? How are you ensuring the drugs are supplied to them? So it triggers a complete set of logistics of people and practitioners. So remote monitoring will, while we'll be able to access or reach the masses, but will create disruptions from a business model as well. And third, another use case that we are also seeing is hospitals are using AI to predict surges in a particular disease area. It's an interesting example. An hospital along with a telecom provider and an AI company, and this hospital was specialized in gastroenterology. They collaborated with a telecom player, and what they were doing is trying to see the mobility of people, because you can get the tower said is, they were, let's say you have a cluster in Gujarat and you find a set of population is, let's say due to holiday season or due to reasons, let's say moving to the state of Andhra Pradesh. Now the food habits are completely different in these two states, and because one state is less spicy, the other state is more spicy. And they are looking at mobility of people. So how many people will come back from this region into this particular region and have gastro-related problems? And therefore, will there be a surge in use of a particular drug? And therefore, they are also ensuring, are the pharmacy outlets and working with the distributors, ensuring those drugs are available. So these are examples where organizations have started using AI for predicting surges in demand. Respiratory. There is a seasonality in your respiratory diseases, predominantly cold or pollution or winter. They are using AI to scrape the web. Let's say as normal individual users, we may go back on a blog and post 26% shortfall of specialty doctors in India. And then what another company had done is, they have created an AI model where collective intelligence of multiple doctors are brought together so that you are able to diagnose and put people on treatment, especially for specialty disease, much faster. And finally, this number is what I always quote, 1.8 million. India needs 1.8 million additional healthcare providers. When I say healthcare providers, physicians, nurses, pharmacists, if you have to meet the WHO standards of 44.5 for every 10,000 professionals. But that also we have addressed. A hospital with an educational institute created a cancer picture bank for any oncology treatment. So they were able to find patterns which were missed out and quickly put the patient on a treatment cycle. So AI is important for us. While it will disrupt the industry, it is still needed for us, because given the size of our population and the accessible and our aim towards accessible and affordable health. And finally, before I close, this is something which I always say: as India, we are a country, we are always possible, because we have it's possible to do immense things, do things differently, and we are able to achieve scale much faster. For example, during the times of COVID, 300 test kits were used, of which 78% were made in India. And of the total tests done globally, 950 million tests were done out of kits made in India. And when we needed more PPE, we had a capacity or the capability to build capacity to manufacture 1 million PPE per day. And when we needed ventilators, our capacity was 10,000 per day. We were able to scale it up to close to 2 lakhs per day. So that's the ability we have. And finally, on N95 masks, we were producing roughly around 100,000 per day. We scaled it up to 800,000 per day. So that's the power of our country, the ability to quickly scale up, adopt new technologies, and even skip a particular generation. For example, we are able to quickly move from 3G, 4G, 5G. So that's the power of India. And AI, while I say it's a disruptor, but it's a positive disruptor which will enable accessible and affordable healthcare for India. With that, I conclude my speech. Happy to have any questions. If there are no questions, either I was very impressive or maybe I didn't make sense. So I will go with the latter or the former, I'm not sure. But thank you very much, and thank you for the opportunity. Sorry? Thank you. Thank you.
Thank you very much, sir, for your valuable insights on AI in healthcare. Ladies and gentlemen, I'll just like you to know, with over 20 years of experience, Mr. Anthony has 20 years of consulting and industry experience and is the life sciences and healthcare consulting leader for the Deloitte South Asia. He is also a part of various industry committees and comes with experience of policy making with the Government of India, whom he is assisting in developing the healthcare industry further. Thank you, sir. May I kindly invite Mr. C.L.N. Prasad, Senior General Manager Sales Malayalam Manorama, to kindly hand over the salver to Mr. Anthony, please. Thank you, gentlemen. We will now have a coffee break for 10 minutes, after which we will start with the panel discussion. Thank you.
discussion? Thank you. Is it good morning? No, it's about a minute past, so good afternoon then. Yeah. So it's my pleasure to invite a special correspondent of the week, Pooja Bereya Jaiswal, to moderate the panel discussion. You can sit there. And also my pleasure to invite the 4 panelists this morning. Dr. Sajan Nair is an MD and MPhil, has been associated with Zydus Hospitals Ahmedabad as Group CEO for more than a decade, has been contributing prolifically to their growth and has been instrumental in initiating various programs that aim to bridge the gap between cutting-edge technologies, innovative medicine, and patients across India and internationally. So, welcome. Dr. B.S. Srinath is a senior consultant surgical oncologist who obtained his post-graduation from PGMR Chandigarh. He completed his higher training in cancer surgery and research in the UK, returned to India in '83, is currently head of Sri Shankara Cancer Hospital and Research Center and managing trustee, Sri Shankara Cancer Foundation. Thank you so much, sir. He's involved in many cancer research projects as a principal investigator and a mentor to many aspiring scientists. He was honored with the Kannada Rajyotsava Award in 2022, last year, by the Karnataka state government. I've kept 2 old friends of the week for the last. Dr. Santosh Shetty is an alumnus of Mumbai University, Tata Institute of Social Sciences and the National University of Singapore. He's an assessor with NABH, has been involved with hospital operations for 2 decades, including as head of medical services at Wockhardt, CEO at Breach Candy, and now executive director and CEO at Kokraben Dhirubhai Ambani Hospital, which is the only hospital in Mumbai to have all 4 international and national quality accreditations. Welcome, Dr. Shetty. Dr. H. Sudarshan Balal was the best outgoing student at Kasturba Medical College and has done wonderfully ever since. He's a recipient of many gold medals in MBBS and MD, further trained in the US, and has been triple board certified in internal medicine, nephrology, and critical care. Has the rare distinction of being professor of medicine at St. Louis University of Medicine in the US and adjunct professor of medicine at Manipal University. Is also a fellow of the Royal College of Physicians, London. So now over to Pooja. Just a word about Dr. Shetty and Dr. Balal. When we first started this in 2020 as a webinar, both of them were part of it. So they've been fellow travelers with our journey. Thank you so much for that, to both of you. At that time, both of them had a lot of worry lines. I think all doctors had at the time, but you look pretty cheerful now, and I'm quite happy for that. Thank you.
Hello, okay. Thank you, Matthew. So yes, we are at the panel discussion with the experts here themselves. That is what the cover story in the week is all about as well. It's on technology in healthcare. We will begin with Dr. Sajan Nair with you. So if you could take the mic. Yeah.
Hello.
Hi. So the last time we were speaking, I remember, you speaking very vociferously about hospitals without walls. I think that is a very interesting concept right there. So, so maybe we could start with that.
Yeah. First of all, good morning. 2 thank yous. One, thank you to the Vanorama Group for giving us the award, and second, thank you to my team at Ahmedabad, Baroda, everywhere, for allowing me to be here. So we talked about the hospital. Actually, just to correct you, sorry, I'm starting on a wrong note. It was talked by Dr. Balara, but that's okay. We talked about taking. So if you want to start, start, or it would be better.
No, please carry on.
You are the one who started.
Right, Dr. Balal, can you please highlight?
At the outset, a big thank you to the Week Group for having us here. It's a great honor and a pleasure to be here. What is interesting is that you have chosen the people to be on this panel for artificial intelligence and technology in healthcare, and the average age of the group, if I may say, is over 65. So I would have thought a lot of younger people would be talking about technology. I see Manish laughing. He's probably making fun of my age, but be as it may, I think technology has really changed the way we practice medicine. And I must say, in spite of all the adversity of COVID, the one good thing that happened with COVID, it accelerated the use of technology. I remember video consults or being mired in a quagmire of legal issues for decades. But 1 week of COVID in March of 2020, the entire thing changed, and it became common knowledge, common practice to have video consults, which changed the way we look at patients, because physical examination of patients was a huge problem. Of course, technology has grown in many other ways. One of the things is, as we had talked about, it is going to change brick and mortar hospital to more of technology-driven hospitals, which could be ambulatory, home care, and of course, daycare. And the need for in-hospital beds will be restricted to only people who need surgeries or people who are very critically ill in the ICU. Things have changed in many ways since the technology has given way. I think the huge impact has been in radiology, wherein imaging has taken a new turn. I think the machines have learned fast enough. And I was with some groups in Delhi, and they were telling me that what they felt was about 90% of the images that they see are normal images, and this is where technology helped. Technology has been able to tell them what is normal so that they can concentrate on the 10% of images that are abnormal. So I think it's been a huge boon: video consultation, remote monitoring, elderly care, monitoring within the hospital, outside the ICU of critically ill patients. For instance, these monitoring devices have significantly reduced the number of in-hospital deaths. We have a code called Code Blue when someone arrests in the hospital. And with the institution of these systems that we have, at least in our hospital, the incidence of Code Blue calling has come down by more than 90%. So I think we have to look at technology as being our partner. It will not eliminate, obviously, doctors like me from the field, but we will perish unless we go with technology. Thank you.
Right, that is absolutely true, sir, right there. And then we also have, I think there is also in the field of automation, lab reports. And when we visited your hospitals for our story, for our cover story, and we saw how beautifully and seamlessly these things flow. Can you please throw a light on that, Dr. Nair, if you could?
Thank you, Pooja. So we are talking about what I understand is operational efficiencies, right?
Right, yeah.
So two things or three things which I think, one of the things which makes us better, and all the people here sitting here and all the awardees, is the cultural fit, which starts from the top. In fact, each of them sitting there, there's a solid cultural clarity which comes from the top to the bottom.
Right.
Second, if you look at all of us, we are all have gotten full-time doctors. So we have eliminated the other things. And then comes the other things which we all as facilitators. Coming to automation, a lot of automation has come into the industry. You look at it from two different angles. One is the documentations, the EMRs and all those things. And second, the doctors themselves develop over a period of time adopting technologies. Okay. Dr. Manjunath was talking about hub and spoke model, if I remember. So we have already introduced, and it was for a cerebral stroke. In Gujarat, last year we introduced a hub and spoke model. And the Deloitte guy friend talked about collaborating. So we have got that into the thing. So now we're collaborating with Medtronic and this, and we have got a hub and spoke model using artificial intelligence for cerebral stroke. Right. Now coming to the laboratory part, that is another area where we have talked about. We have put up a lot of middlewares. I think most of the corporate hospitals sitting here have put up middlewares. So we got the results verified very fast. Right. Now we have got dashboards into that. Right. And that makes it easy. The wastage is less. Things are accurate, almost 99%, and saves a lot of time. Third point, when it comes on systems and everything, is the surgeons learning, right? The robotic things. Right. We talk about robotic surgeries. Right. Actually, robotic, the other way around, they are assisting the doctors to do better surgeries. The robots are not doing the surgeries. That's where all the things make a difference. So overall, all of us sitting here, having taken this journey to adopt things and move to forward, and that's how the systems move.
Right. And in the area of oncology, sir, Dr. Srinath, if you could throw a light on how really, the complete domain of oncology is kind of facilitated by tech, if I could keep it that way.
Yeah, thank you, Pooja.
Yes.
There is tremendous scope for the artificial intelligence adoption in the cancer care. It's an evolutioning field. For example, in areas where we talk of diagnosis, as Dr. Shetty said about the radiology or MRI or PET CT scan, where we have images which are of very high quality, which are interpretable, which are digital in nature, the study could be much better. These machine learning methods can actually give accurate diagnosis, where the interpersonal variation between the observer variation of various radiologists may differ, the experience levels may differ, but the machine knowledge will give us the accurate diagnosis. This is one area where there is going to be tremendous scope and applications which are going to be quite successful. Secondly, when you come to the diagnosis, for example, pathology, huge numbers of slides are being seen by the pathologists every day in and out to make a diagnosis of cancer. For a simple example, if a breast cancer specimen is to be evaluated by a pathologist, she or he will have to see at least about 100 slides under the microscope. And it's quite strenuous, and also it is not infallacious. Now, when you have digital pathology system with you, it makes the observation very easy, and finer details of high resolution, which are actually missed by the doctor, can easily be picked up over a period of time. As we go ahead, this is going to give much more accurate diagnosis. Now, for example, in colonic carcinomas, now we have started making a subclassification based on the convolutional neural network artificial intelligence. Now the thing is, it's going to give us a different diagnosis than what the conventional pathologist would think, and this would be more suitable for the treatment. Now newer algorithms are likely to come, and choices of new drugs is going to be dependent based on this. So I think in every area, even in the early diagnosis, the specimens, patterns of the specimens are actually examined. And when it is submitted to dissection of various layers of neural network analysis, they will be able to actually predict and say, this is likely to turn into malignancy over a period of time. Now, we are not there yet, but we are hoping that we will be there soon, so that this is going to benefit the society in a larger scale. Now, this is going to happen probably, if not too soon, we will see these changes happen over the next decade or so. I think we have time to adjust ourselves, learn the way through, and then also start adopting it more freely, because this is all being developed in the field of engineering.
Right.
There is a strong need for the clinicians to interact with the engineers, work together and develop these. It will be much faster, quicker, and more accurate. And then if it is doctors are a part of the whole system, it will be adopted much more easily by the society which is going to come. But one word of caution I just want to make is the question of, privacy of data. This is going to throw huge amount of data to the society. Everyone will be handling this data. The patient will be able to access it directly. I'll just give you one simple example. If the patient can know through this artificial intelligence means that we create in the future, just imagine this, that if he comes to know that he is going to survive only for 3 months or 2 months, what would be the emotional issues that he is going to face? Who is going to tell him that? Now, today, I frequently see complaints coming from various patients. And they say, we went to that doctor, directly in front of the patient, the doctor said that no, you have got stage 4 cancer, nothing much can be done. Should the doctor tell all these things to my father? He should not have told. He is not a good doctor. Now, the equipment machine is going to tell them that you are going to precisely live for 2 months and 3 days and 1.5 hours. Who is going to be responsible for this? Now, this privacy data, is the society ready for it yet? I do not know. So the thing is, this is going to throw up lot of knowledge, lot of information, which needs to be properly understood, evaluated, released to the society in small installments so that the society is also prepared to take. This is my, I am not an expert in artificial intelligence. Basically, I am a doctor, but looking at all the things that are evolving over the last decade or so, some areas I am very happy, but in some areas I am concerned.
Right. No, you expressed it perfectly. I think that is a matter of concern. That is true. Dr. Shetty, I would like to bring you in here. And I would also like to ask you about this. What do you think about the concern of data, as Dr. Srinath put it? Also tell us about the last mile connectivity. Accessibility of healthcare is just as important, I think, as is quality of healthcare and affordability. So you please throw a light on this.
Yeah. Thank you, Pooja. And at the outset, I'd like to compliment the Malayalam Manomara group for putting this conference together and for the awards. Like you rightly said, the last mile connectivity is the big missing piece in this whole Indian healthcare system, where Dr. Manjunath and Anthony both stressed on the need for making healthcare more accessible to the rural India. And when we talk of that, when we talk of last mile connectivity, I think technology can be a very, very key enabler. Dr. Balal mentioned about how COVID has changed the behaviors as far as adoption of technology goes. Now, sitting in rural areas, using technology, using 5G, using IoT, wearables and other devices, we will actually be able to make sure that quality healthcare can be accessed by some of this population. I'd just like to take a point from what Dr. Srinath mentioned, because we are doing some of this work in the area of cancer. So when we decided to set up some cancer centers, we identified districts in Maharashtra, 18 districts which did not have a cancer facility, which did not have radiation oncology. And we went and set about radiation oncology services over there. The biggest challenge was, how do we get radiation oncologists to go and work in places like Akola, Gondia, Sholapur. These were cities which even me sitting in Maharashtra, I had to look on the map to see where they were. So very difficult to get people to go there and work. But we were able to identify some local young radiation oncologists, and with variant technologies, we were able to build AI-based algorithms where treatment plans could be made locally, and using technology they could be transferred to our center in Mumbai, where the plans would be validated by our senior radiation oncologists, and the care could be delivered over there. So patients who otherwise would have had to come to large cities, they could access high-end radiation oncology services right over there of a particular level and quality, which comparable to Mumbai, using technology. So technology can be a very, very key enabler as far as last mile access goes. Technology, I always talk of AI not as artificial intelligence, but augmentative intelligence, because it is actually enabling the doctors to do better. So if there are physicians, physician assistants, nurses in rural areas, how do we use technology as a tool to make sure that we are able to either transmit images and give opinions on them, give some diagnosis, use telemedicine, teleconsultation. All of these are going to be critical as far as providing access to rural India goes, because we said that 60–70% of our population is living there, and we can only use technology as an enabler. Similarly, technology will also be an enabler for training. This morning, Dr. Manjunath mentioned about the quality of doctors that are coming out of some of the medical institutes and the kind of exposure that they have. So how do we use augmented reality based VR headsets? How do we train people on robots, on simulators, so that we are able to upskill them? again, that is a very, very important part as far as using technology to provide access and quality healthcare goes. I mean, Anthony mentioned this morning about being an engineer in healthcare. I strongly believe that engineering and medicine, the lines are slowly getting blurred. There is more and more engineering coming into medicine today, and the future of medicine is going to be heavily dependent on engineering, whether it is medical technology, whether it is information technology, or whether it is automation. And all of these are going to help to improve patient outcomes, to improve access, to reduce errors. Because finally, at the end of the day, that's what you're trying to do. And technology can augment the whole clinical delivery system. So that's my point.
Right. And Dr. Balal, I would like to bring you here. You know, this is exactly what you said as well. You know, how technology is just going to complement and supplement. I mean, it cannot replace the human presence, right? I mean, can you talk more on that, you know, from your own personal experiences and talking to patients, and what do you think about it?
I think that's a very important point you raise, more so in the social situation that we are in and in the cultural situation that you are in. In the good olden days, I remember when my grandmother had a surgery, the entire family, about 30 of us, went to the hospital and stayed in 2 rooms. And she stayed in the hospital for a month for her gallbladder surgery, and everyone was happy. Whereas now you have nuclear families, the patient comes most of the times on their own, or maybe with one attendant, and there's no one there to speak to except your phone and your TV. So things have changed. I still have patients who have told me, what is this, doctor? When I came to the hospital in the good old days, the doctors will look at me, talk to me, pat my back, and write down the notes. Now they only look at the computer, they don't even look at me, and they keep typing on the computer, so I don't know whether they've heard me or not. So I think empathy, sympathy, and acknowledging the patient is as important as what data you enter. And I still see patients who travel almost 1,000 miles from the remotest part of India to come to Bangalore, about 48 hours to come, 48 hours to go back, and spend half an hour with us. And I asked them, what is the reason? Because most of these things could have been done virtually. They said, no, doctor, we'd like to come say hello to you, see you smile, see you examine us. And that gives them more satisfaction than the actual treatment, which I think is pretty much common for everything. So in the process of adoption of technology, we should not forget our empathy, sympathy, and compassionate behavior. I think they should go hand in hand. And the other thing that I would like to say about anything we introduce in patient care, one is it should be accessible, which means the rural India, as Dr. Shetty said, should be accessible, should have the means of accessing us. It should be affordable. No technology will survive in India if it's more expensive than what the current therapy is. 3, it should be safe for the patients. I don't think any one of us would travel in an airline where a Boeing 747 crashes each day, but that's exactly what's happening in medicine. About 100,000 people or more die of medication errors, and obviously technology can be used very effectively to prevent that. Then the most important thing is that the outcomes of technology-driven healthcare should be better than the conventional outcomes. There's no point in bringing technology that's expensive but has the same results as what you would do earlier. So I think technology should fit into the bills that I spoke to you, and there should be a smooth amalgamation of the human touch and the machine touch.
Absolutely. Yes. Yes.
Thank you, sir. I was just going through the week.
Yes.
It's the journalism with a human touch. And here is the art of good healthcare. Yes. So that's exactly what we are also in the business. So one of the things where technology has enabled, yes. See, we can't, the emotions can't be ruled out. We are talking about rural and urban people. Now, my experience, I've got 2 hospitals in tier 3 cities, 2 hospitals in tier 1 city or two cities. Right. We get a lot of rural population. Like sir said, they need this connect. Now, one of the areas where they are helping, and this is something which, if you look at, one thing is common in healthcare, when we look at patient care, experience, outputs, waiting time. Yeah. Right? True. Gujarat is one place. You have been to Gujarat? No. No. Please do come on a Saturday, sure. Sunday. Go to a restaurant. Okay. There will be something called as waiting time. Right? Nobody has any problem with the waiting time. Okay. They will wait for 1 hour. They come to the hospital, poor guys like us sitting there. Yeah. and the first thing they call is the waiting time to see the doctor, right? So that's a challenge which we are still trying to solve with technology. Somewhere we have been able to solve it, but overall it's still a challenge. Other thing that sir said was about this communication. People are typing. Now, if you look at technology, it has evolved. It has evolved from initially there were secretaries typing, then now there's something which is voice to text. Now, voice to text has evolved to such an extent, patient and doctor can talk anything they want,
Right.
and only the relevant clinical information is cached. It has come to that level. So it's been implemented. We are working with one of the companies. It makes it so simple, right? So some of the engineers are also like Santosh says, they also started understanding that there's a human touch, human element which we have to improve. And this is one good thing which is happening, which we see as a future, which will sort out a lot of issues of the patient and doctors.
You use the voice to text
Yeah,
in
we
your
have started
hospitals
using.
right now?
We have started using. The other thing is in pilot project. It is a company called Ognito.
Okay.
They are coming with this patient to things. So I'm not supposed to speak more about that, but then fine, we are working with them. So maybe we tried first working with radiology, pathology, independent doctors on discharge summaries.
Okay.
So they got it done. Now we have moved to the next step with working with them. Then that's where the engineers come in. They understood. And it's so beautiful to see them not. If you see the things, there were a lot of things which evolved. There was a pen which came in, Doxper.
Right.
So they started writing with pen and you could get it. So if you just study the OPD requisitions, how it moved, now today I think this is what is going to change OPD things. When you have a voice to text, things got tested and they take only the clinical things.
Yeah, that's what. So it makes the decision on its own, like selectively.
It picks it up.
It picks it up.
So now as of now we were doing at 94% specificity.
Right.
That much is good enough for a start.
Wow.
Going forward it becomes better and better.
Incredible. Right. Dr. Santosh, I would like to ask you, in terms of oncology, there with so much burden, case burden and all, tell us how do you manage and how is technology really helping you solve that problem with queues upon queues, as Dr. Sajan said. How do you address it in oncology?
Yeah, it is
Dr. Srinath,
two things in cancer. One is emotional instability of the people who are coming there. Second is adoption of technology. The dilemma is actually, while you adopt the more newer versions of the treatment, therapy, which has actually given better cure rates, you will have to keep on changing your equipment, change your methodologies, and it's going to be very expensive. If you remain keeping the old machines and old technology to treat, then only the doctor knows that he is unable to, his hands are tied and he is unable to give the best to his patient. This dilemma is less often spoken, but it is very true. For example, in radiotherapy, we have evolved over a period of time. It was straight cobalt therapy. Now, subsequently, we are focusing on SRT, SBRT and all that, which is even on a moving structure in the body like lung, if the tumor is moving, you can track it and give radiotherapy. Now, that means it actually prevents the radiation to the surrounding structures and it only focuses on the tumor and radiates. Now, if this technology is not available in an institution, now the patient is at a disadvantage. So now this means that the technology adoption in cancer is going to be much more expensive. Going forwards in every area it's going to be very expensive, but it is going to give better cure rates, better survival rates, better comfort to the patient, all that is known. This is one area. You talked about the queues, long waiting queues. What we also do is the same thing. We have identified the doctors who are always busy. It is that some of the doctors are much more popular than the others. You can't help it. Those doctors, we have actually given them the voice to text. You have Dragon and you have so many other, this one. They have the medical software loaded into it. So when the doctor speaks into it, it gets converted. Of course, there will be discussion, will also be recorded if it is. It is fine to have the patient's questions also on the computer, it does not really matter. But the thing is, what the doctor can explain, he can go back and sit and see what he has told the patient. It is very important for his own learning. If he trains himself in speaking into the dragon, his efficiency will also improve. So for doctors who see about 30 to 40 patients per day and more, we have provided them with dragon. Radiologists, pathologists, consultants with busy workload, they are all provided with this equipment, and they directly enter the discussions into the computer. It is recorded. It is extremely important going forwards even into the AI in future, in developing new algorithms, treatment and all that. Accurate data will have to be entered into the case file. All of us here today are practicing hospital information system, electronic medical records. Now that is going to be the standard of the day. And when you have to have structured data which is actually entered into the case files so that they can be interpreted, questioned, new algorithms can be created, we can tie up with various industries and then develop new technologies. So I think this is another thing that is happening now. This will make the life of doctors much easier. Patients can carry the discharge summaries on their mobile. They can get their pathology reports in the evening on their mobile in the Androids if they have a hospital app. Patient app is provided to them and they can directly read their reports and go to anywhere. There is no, as far as the patient is concerned, it's only important for us to identify who is the responsible person other than the patient to whom we can deliver this information. Once we identify, we can actually, this makes life, we don't print anything, we don't give the patients any printed copies of the reports. It's all available on their mobiles. They can save it and keep it for themselves and show it to any doctor for second opinion. It makes the life of the doctors easy and the hospital also gets benefited. It is necessary for going forward when you see large number of patients, outpatients, footfalls in the hospital, it is necessary that these things are streamlined. Of course, we have to keep into consideration the serious nature of maintaining the privacy of the data and the patient's interest in this.
Right, absolutely. And that brings me to the complete lab automation that is there at Kokila Bin Ammani Hospital in Mumbai. So throw a light on how did you all really do that in a short span of time? I think last year when we visited, it was just in the process, and then within months it was all ready. And tell us how does it really work? Tell us the seamless operations, just like Dr. Srinath said.
So the idea of automation is, one is of course, to reduce wastage, to improve efficiencies, and to give better turnaround time to patients. So when we evaluated, we said that one of the challenges we were facing was the number of manual interventions in the process, and that's when we decided to look at total lab automation as a solution. This we are primarily using for biochemistry and hematology, where the entire system runs on tracks, all machines are interfaced, and Sajan mentioned about middleware. So we have a middleware, we have got softwares with AI capabilities. So there are few advantages if you look at it from a patient point of view. Number one is the amount of blood collected from a patient is very little. So on a much smaller volume of blood, generally if you see, you go to give blood, the phlebotomist will collect it in 3 tubes, 4 tubes. Here you collect it in 1 tube, put it on the track, and the machine, the automation will automatically pick out samples from that and put it into the different tubes. So amount of blood collected is much less. Secondly, the reagent usage. The wastage comes down totally because it is the machine which is actually picking out the reagents and making sure that appropriate level and amounts of reagents are used. Thirdly, using AI algorithms, you are able to prioritize samples. Okay. So you know that ICU samples, emergency samples, ABG samples, so they are all on a priority track. There is a large display which shows the status of every sample real time. Okay. So if you want to see, okay, this is a sample which is going to take some more time and I want to put it on a fast track, you are able to do that. So overall, It improves the turnaround time. We are able to give patient reports much earlier. There is predictability, reduced interventions. So it's a much better patient experience, more safer. And the reports, once they are ready, they automatically get emailed or they go out in the form of WhatsApp messages. So the interventions are minimal. When we have a challenge in healthcare, because to get quality technicians also is a huge problem. You know, because newer labs are opening up, newer hospitals are opening up. So how do we make sure that automation actually helps in improving or augmenting the workflow? That is what lab automation has been able to do. And clearly AI, you know, in diagnostics, you know, as all the other panelists have mentioned, is really going from one level to the next. The challenge, of course, continues to be on the clinical applications. How do we use it? How do we use it effectively? And at the same time, make sure that the patients get a good experience. Like, you know, during COVID, we saw all hospitals, the teleconsultation rates, the video consultation rates went up to 30%, 40%. But post-COVID, they are back to 3%, 4%, 5%. So patients are still, like Dr. Balal said, preferring to come back to hospitals. They want to meet the doctor. They want, even if it is for a small thing, because the emotional connect, the personal touch, that can never go out of medicine. You know, using AI, we can only see how do we make the doctors more efficient, how do we make the processes more efficient. And finally, it's going to be a mix of physical and digital. As they say, phygital is the new terminology that's coming into healthcare. So how much of digital takes over the physical part is a process of evolution that we'll have to see how it comes to.
Right, phygital, that's the term I think we need to look forward to.
So adding on to what he said, phygital came in 2007, I think.
Yeah, around that time.
And people like us got to know about it in 2019. So we almost, all of us sitting here get almost 200 mails a year maybe from various companies. Two words are very common. One is phygital, second is omni-channel. So we never understood what it was, but now slowly we are understanding what it is. One of the things what he says is like very important, which we also agree with, the emotional connect cannot be remembered. Whatever Anthony says, and where is Anthony? Yeah, he says is, okay, AI will do all these things. India is an emotional country, right? And we doctors are also very emotional. So the one difference between engineer and doctors is being emotional. So that is going to be the key as we go along, right? And obviously AI will improve all the processes, will make it easy, like in cancer and all those things. If you remember many years back, we had this histopathology, the IFB Watson. Yes. It was before time, right? It came in, but it went off. So it was before time, but all this pathology, radiology, support systems can always be done by this AI and other integration. Rest, you will have to be, in serious cases, you will have to come to hospitals.
Right.
Screenings, small screenings and all those things can always be taken to the peripheral level. Like we all do in the hospital, continuous glucose monitoring, right? We have stopped pricking. A diabetic patient doesn't want to be pricked 5 times in a day in a hospital, right? So that we have moved out. He has a sensor. That can go to periphery also when we send the patient home, and we can have a track of those. So a lot of things are coming, but at the end, a little bit of emotion will still remain.
Right. So we've spoken about operational efficiencies, and as you said, of course, the support systems, they will always be there, and AI can take care of them. But there is also this very interesting aspect of precision diagnostics, you know, where AI is playing a very interesting role. And Dr. Srinath, can you tell us about oncology? In oncology, precision diagnostics is huge. You know, it's evolving, of course, but it seems that the machine, that AI can spot a tumor, especially I think in the case of breast cancer, even before the patient really feels, or even before it really becomes symptomatic, you know, becomes problematic. Can you throw a light on that, please?
Precision diagnostics in oncology is an upcoming field. For example, by studying repeatedly, by studying the mammograms of a patient taken at different intervals, the finer digital images of that can be interpreted, and we can predict which of these images, where it can turn into malignancy. So we can actually do that. Until now, we were under the impression that breast cancer can only be detected when it is seen in the mammogram.
Yeah.
Now we are talking of, we are not yet there, but we are talking that these are the fine signs that we can detect by neural network, artificial intelligence, that this foci or a small spot of 3 millimeters or 2 millimeters in future can turn into malignancy. This kind of precision diagnostics is coming. Besides that, in a much larger area, what we are looking at is the advantage of getting the correct choice of drugs for a particular cancer. Now, this has been a dilemma for most of us, all the doctors. Now, for example, I'll just elaborate it a little bit more. We know that we have now so many newer targeted therapy agents, what we call, monoclonal antibodies and all that. Drugs which are directed against specific cancers are now coming into the market. Right. Large number of them. But even they are only effective in about 20 to 30% of cancer patients, but not in others. We are unable to say who are those 20% or 30% of the patients who are going to get actual benefit from that particular drug. Now, but we know, we try, each drug is probably about $1.5 lakh per injection, but we give 3, 6, 8 injections and we find that there is no benefit to the patient, then it's a disaster. Now, we do not have any tool as of now which can actually say that this drug certainly will act in this particular patient. Now, this is marrying the tumor behavior and the characteristic with the drug that is available. Now, this depends on molecular diagnostics, proteomic studies, genetic sequencing studies, and also outside the tumor cell, in the tissue, what are the chemical reactions that are happening. I am talking in colloquial terms for better understanding. Yes. So that we understand the milieu, the work going on around the cancer cell, so that we can choose the correct drug. Now, this is one area where AI is going to help us a lot. That is going to be right now we are using this precision diagnostics in some of the molecular studies. Right. We are already there. But even then, see, for example, I'll just give you one example. A lung cancer patient, a young man of about 55, was diagnosed with lung cancer, and we did all the genetic studies, and we found that he had a genetic abnormality which was reflected in what we call EGFR, epidermal growth factor receptor positivity. Based on that, we administered certain drugs to him. 3 months later, we found that he had extensive spread of the disease, and this drug in fact had not been effective. So we went around and tried to find out. Immediately we changed the course of treatment, but yet we also continued for finding a solution for this. And we found that this tumor also was secreting a retinoblastoma protein, RET protein, okay, a gene, which was actually counteracting the medicines that we were giving. We didn't know that before. So the thing is, now we need a comprehensive tapestry, an image of all the things that are happening in that particular patient, for us to choose the correct drug. Now, I think this is the dilemma that we are facing as of now. Hopefully, we should be able to get with precision diagnostics, with deeper learning of what we are seeing. Maybe in a decade's time, we will be able to match the disease and the drug so that the cure rates will be much higher.
Meaning clinical decision making, basically.
Yes,
it'll help
it will be
you
made
in
easier.
making a clinical decision making, right? So as into which drug to use when, and right, okay. Does that also work in other areas as of now? Including oncology. I've heard in cardiology also AI is helping a lot in terms of clinical decision making, and various other aspects such as ophthalmology and stuff. Okay, so now since we are on the subject of tech in healthcare, I would like to ask all of you, how do you all use technology in your own healthcare? Share your own personal experiences, the apps that you all have on your phones, and how do you all use machines for better health management of yourselves? Yeah. Let's start.
We have a wonderful hospital, so I don't need to use much technology because I have doctors and healthcare personnel available in most of the cities where I need it in a lighter vein. But we do use a lot of remote monitoring devices. I'm not wearing that watch today, but my iWatch checks my heart rate, looks whether my rhythm is good, are my emotions okay, am I smiley or not, is there anything I need to do to smile better. I think wearable technology is a major thing and it can predict many things. And I was with someone the other day on a very interesting note. They have these cameras in waiting periods in the hospitals because you have seen that violence against doctors, vandalism in hospitals and so on and so forth are going up. Apparently, this technology is used by the police and other law regulatory officials in public areas. It looks at the face of a given individual and sort of picks up someone who is very sad, angry, and might get destructive. So you can forewarn the authorities that there is trouble in that table there. Please go and take care of them. So similarly, I think many things in medicine can be predicted. For instance, in my own field of nephrology, acute kidney injury, especially in the ICU setup, now can be predicted based on artificial intelligence, based on the patterns that the machine has learned in the past. And if I know that so-and-so is going to develop acute kidney injury in the next 48 hours, I can take measures to try and prevent it, which is potentially life-saving, because developing acute kidney injury in the ICU is not a good thing. So there are ways and means of prediction of morbidity and mortality using machine learning by algorithms that the machine learns on its own and is fed into the machines. So I think we are looking at a very exciting future. Certainly an exciting future where the doctors will still continue to play a major role, at least till I retire. And the machines will continue to advance so that it will be a combination of man and machine that will deliver the healthcare for the future.
Right, great.
So I think predictive analytics is going to play a very, very important role both on the clinical side as well as on the business side. So if you look at clinical side, I mean, Dr. Balal gave some examples. We are using some of those. I mean, there is, for example, in stroke, generally patients come in with a stroke. You don't know whether the patient is in a window period or not, you know, whether, but now after doing an MRI, you know, there are softwares which will actually predict that will this patient benefit from an intervention or not. So, you know, there is a rapid AI software which has been done based on a study of 1600 hospitals and about 10 million scans. And clearly looking at the nature of the clot, one can predict that, okay, you do a interventional procedure, this patient will 80% benefit.
That is after the golden period.
Even after the golden period. So just based, because sometimes you don't know when the patient developed the stroke. Patient says, I felt some weakness or I was sleeping. So when you do the scan, you use the software, you are actually able to predict. Secondly, early warning signs, like what Dr. Balal also mentioned. In ICUs, nowadays, you know, technology is being developed where monitors, based on monitors, ventilators, one can actually predict that, okay, this patient is at a risk of developing a heart attack or a kidney injury or a stroke if, you know, things are not controlled within the next 48 to 72 hours. This is very important considering the fact that our quality of people working in these areas is a challenge. You know, the nurse attrition, shortage of resident doctors. So these are areas where technology can be a key enabler to predict the likely outcomes and for help us to intervene much earlier and save lives or reduce morbidity. Now on the business side of things, based on all the data that we've collected, it's very easy. Like we are using some of these tools in our BI apps. I know that, okay, every Wednesday I can expect so many admissions. Every Thursday I can expect so many admissions. On this day I know so many theaters will be needed because so many surgeries are going to happen. So I can predict and plan my beds, my theaters, my OPD appointment slots, all of these based on simple basic machine learning.
And faster.
And faster, of course. So I'm not relying on just intuitiveness, but on actual data to make sure that I know that, okay, this is a Diwali month, my occupancy will dip by so much. Sundays, this is what is going to happen. So based on actual historical data, it's very, very easy to work out algorithms and which will aid my admission staff, my call center, my booking staff, so that appropriate resources can be planned and allocated. So predictive analytics is going to be a big piece in both clinical as well as business intelligence.
And you have to tell us, what do you do for your own healthcare management using technology?
Well, I am still using the most rudimentary things, which is that I don't take the elevator. So
Okay.
even if I have to climb 15 floors, I'll always climb. And of course, an iWatch is always a big help because
Right.
it always shows where you are and what you are doing. But
Right.
I wish someone could work on technology where the watch doesn't need to be charged every day.
Yeah, that is a hassle. Right. Dr. Srinath.
Yeah, personally speaking, these days all the mobiles carry your data. How much you walk, how do you exercise, how much of energy you consume, and what you eat, everything can be actually determined. Occasionally I do follow that, but I keep life simple because I need to keep myself fit. So I do my regular dose of yoga and 20 minutes of exercises in the evening every day. That itself will tell me when body tells me when I am right, I am fit or I am not fit. If the next day I cannot get up in the morning, I know things are not good. But one thing is about the prediction that what we are thinking. Sometimes when I think of it, I really shudder, because had we known that this COVID is going to come, if we had artificial intelligence and its predictions, that COVID is going to happen in this year and this magnitude, would it have changed the world? Because we lost millions of deaths. It is necessary that science should advance. It is essential that all of us will have to work towards that for the benefit of the humanity. Even I am looking at in a larger scale. I think while each one of us will have to be careful about our own life, but I think this explosion in science is necessary, because what we have gone through during those 3 years has been, horrible to say the least. And we never knew whether we will be sitting here today and talking like this. Most of us, doctors also, going in the hospital. Our hospital was also a COVID designated hospital. Day in and day out, father, mother dying, old wife living, and all the other 5 people in the family wiped out. The stories that you saw and during that period actually shook every one of us. We should all pray that such a thing should never happen. I think the artificial intelligence or the prediction, what we do for the future science, should bring us these solutions, at least for the sake of the humanity.
That's too emotional, sir. I think we all need to pat ourselves also, because the way we fought COVID, nobody could have done it. I think that much we deserve for ourselves. Very well said, sir. And I think each of us here sitting can relate to the moments which we went through. Thank you, sir, for bringing the topic. So nice of you. The first question is what I do for personal. That's the wrong question, wrong person. So that is deleted. Maybe this can be an inspiration for the next year. I can come back as handsome as both the professors here.
AI can help you, no? AI and technology can help you.
I don't know, but let's park the question. That's always better. Coming back to what we do, is WhatsApp a AI-based channel? Just our understanding.
Yes, I think it is to an extent.
So all my hospital, we have got good people who use WhatsApp extensively for communication. So sometimes we have to come in and say, boss, leave WhatsApp, let's come to that. So that's on the other part where there are groups and groups and groups. I don't know other hospitals what they are doing, but everybody has a group. Operations group, medical group, engineering group. I don't know how many Santosh would be having, right? So these are the groups which work. On the business part and other parts, like Santosh says, radiology and laboratory, almost we all are working on the same protocols. MRI protocols, code white, code blue. Right. The beauty is now we are able to track the data because it is coming on an application. Right. The 60 minutes duration, time period, opening. That's fantastically being done. So that is done. On the cancer front, more and more molecular things are coming in. Now, one of the problems with the data I wanted to ask sir was, because we are still relying on a lot of artificial intelligence, what they are throwing the results or what they are saying, it is on foreign data. Indian data is still evolving. It will take us some time. So all the cancers, I think how they react to something, I don't know. But that's a challenge which we'll have as we go on working. But all the institutes are now working towards that, getting our own data, working out molecular precision things. Most of the clarity is coming out, okay, this is a drug which can be used, this is the first line, this is the second line. Other things which most of the small things which we use, dietitians, how do they correlate with the diet? These are very important for patient-centric view. When the patient is admitted in indoor, he needs to be knowing how many diets, what time. So we use systems and processes which tell us, okay, this is the time where you will get the diet and all these things. Now in a hospital, a challenge is always a call bell. And most of the, and this is a very small point I'm taking, from the very basic thing. Most of the patients complain about call bells being not attended. Right? Very simple call bells mean. Nursing don't come, everybody gets irritated. They think, and if you are paying more, you get more irritated. That's how life is. So then that's where we are starting working on. We're getting a data, how many call bells they are doing, what is the reason they are calling out. So they are getting into a system, and then we are predicting, okay, aaj isne 10 baja hai, kal ye kitna bajayega. And that is very irritating for the nurse, who is poor nurse, who has to run up and down. And that will make a lot of difference in the operational things. And rest of the things, like we all are working, looking for a progressive involvement of AI in all the data things, analysis, and throwing up results. Only problem with AI is we are worried about the chat GPT generation, right? We were sitting at a gastroenterologist, we had a neo-rich person looking into chat GPT, understanding the difference between ulcerative colitis and Crohn's disease, right? And then telling me your doctor is wrong. So ChatGPT also, you have to give the right questions to give the right answers. So on that, on the endoscopy things, since I came to that point, we are doing biopsies which image guided artificial intelligence. We are tied up with a company. So somebody said collaborative. We are collaborating with companies to come out with results. So maybe we can throw out the histopathology of the biopsy. We can take the test out and give treatment on the artificial intelligence. It will take another 2 years and we will be able to do that.
All right, great. Thank you so much. This has been quite an interesting, yes, please. Yes, it's throw it open for the audience.
Just a quick question. So you all talked about the pros of technology and artificial intelligence and all that in medicine. In journalism, the traditional thing was print, and then technology came in, and we had social media, and then there was a lot of fake news, right? A lot of fake news started spreading, there was no control over it, whereas the traditional form print was more credible. Now, I'm just saying now with technology coming so much into medicine and to the thing, I'm just wondering, I'm going to try to compare it with journalism. Today we can talk about an exit poll in Madhya Pradesh, and we can get it wrong. Using technology, we've used technology, tried to get the best samples, and we said that Congress is going to win Madhya Pradesh when tomorrow BJP is going to win Madhya Pradesh. But BJP wins it, we got it wrong, life goes on, it's not the end of the world. But in your profession, if you use technology and you get something wrong, it can be the end of the world, literally end of the world, and life doesn't go on. So how do you manage technology in such a thing where how can you make sure that technology has to be so accurate in a profession like health, which is so important to all?
Can I? That's a very important question. Actually, there is no scope or no place for any errors as far as human health is concerned. I think that is the reason why in every technology that we adopt, we make sure that the results are validated properly, the machines are checked regularly for quality assurance, and every aspect of the technology is being studied at every level of the, for example, if this patient's blood is drawn, the name of the person who draws the blood is written, the blood sample is barcoded, the same barcode is entered into the computer in the biochemistry or pathology lab, and the results are read out based on that barcode number. So the thing is, personal involvement, individuals' involvement in the entire chain of events that happen is actually minimized. For example, when you want to give radiotherapy to the patient, which is very dangerous if it is given wrongly, the CT scan or an MRI or a PET CT scan or a simulator will create the image of the organ for which radiation is to be delivered. Now that data, that image is transferred to the computer of the physicist. Now the physicist creates a plan of action for giving radiation therapy. The areas which require a heavy dose, the areas which require lesser dosage is all marked out on the computer, and then he gets the radiotherapist, the doctor, to come and see. And of the 3 or 4 such plans that were created by the physicist, the consultant will accept one and modify it if necessary, and then this entire plan is actually pushed into the computer, attached to the radiotherapy machine. Now all that the patient has to do, the technician has to do, is to align the patient's position on the radiotherapy couch, for which he uses vertical and horizontal laser beams to be very accurate, and limits the patient's mobility while he is lying on the couch by fixing his body into a particular position and test the accuracy. That's all what he has to do. The dose, the direction, the movement, everything is actually controlled by the machine. Now, so we entirely depend on the technology or the machine to deliver the accuracy of treatment, but at the same time we keep on checking on the machine whether it is actually delivering the job. Now this particular thing is very important, otherwise errors will happen. As Dr. Shetty said a few minutes ago, wherever there is more of human element involved, there is likely to be more errors. We keep on bothering and telling the doctors and the nurses to be very careful about it. For example, there are medications who have similar names, injections who have similar names, similar appearances. It can be mistaken and a wrong medicine can be given. It can cause even death to the patients. So he said about 100,000 deaths happen because of wrong medical. That is more dangerous than actually what we see when we adopt the newer technology. One thing he was talking about, one issue you raised, and that is related to ethnicity. All the knowledge that we have, even the textbooks that we read, are written by the Westerners. And for us, that is the gospel truth. But we are realizing that we are ethnically we are a different group. We digest the medicines in a different way. We don't tolerate some chemotherapy drugs like the way they do. And our metabolism, what we call drug metabolism, differs. So, and our genetic configuration is also different. So in India, we have already started one. Indian Cancer Genomic Atlas has been started, just like CGA. Cancer Genomic Atlas was worldwide. It was started by American Cancer Society in 2009, and we have a library of genetic patterns that are seen in various types of cancers. Each cancer, for example, tongue cancer or breast cancer, we have about 500, 1,000 patients' gene data, genetic data, which will tell us as a library, we can refer to it and see what was the genetic disease in that particular patient, what do we expect here in India. But in India, it is now throwing newer information that it is slightly different from what it is in the Western. So we have in India, we have what we call Indian Cancer Genomic Atlas. 15, 20 institutions are involved in generating this particular genomic data. We are providing this to the ICMR on a regular basis. our institution is also a member in the ICGA. So this is going to actually tell us how are we different from Westerners as far as response to therapy is concerned, or in therapeutic choice of drugs are concerned. That's going to be very interesting. It's again a matter which we will see some solution in the next 5-6 years.
Right. Sir, yeah, I just wanted to know, so when the machine, throws up a clinical treatment plan, is there ever a conflict between what treatment plan you might be thinking and what treatment plan the machine might be thinking? And then how do you decide, how do you choose?
No, we actually decide ourselves. The machine is only a thing which will give us the information. Information will have to be culled, will have to be discussed, will have to be analyzed, and the doctors will have to come to the conclusion as to what is the appropriate treatment. Besides, another important thing is the machine does not decide on the age, on the sex. It does not decide on the type of cancer that we have. The individual is a human being that is standing in front of us. He is in life. He is the person whom we are going to treat. We can't treat the machines. So this is a challenge, that this is a responsibility of the doctors to choose the correct drug. He will have so many other comorbid conditions. His kidneys may be bad, his heart may be bad. Choosing the drug is not guided by the machinery. Information as far as the diagnostics is concerned, yes, we depend on that.
Coming to that question,
Yes.
before I answer your boss, there's something called two types of medicine. One is known as evidence-based medicine, that what people publish. And there is something, the eminence-based medicine.
Right, okay.
Eminence-based medicine is the years of experience the doctor carries. So it's not going to be that, even if you show the evidence, there is going to be the element of eminence which they will be using in
Right.
Indian context.
Right.
As regards boss's question, the only analogy may be a little off the record. We don't have to worry which political party we are supporting. Or we don't want to worry. Our patient is neutral patient. So the only reason we have to do is look at him and cure him. And like he said, medication error is known across the world. USA it is the third biggest killer, right? But we put policies and systems in place to prevent. Where AI help is in barcoding, like pharma, giving medicine. You have SIMS in the system which shows drug-drug interactions.
Right.
You got food-drug interactions. Everything is in the system, which helps us.
Right.
But still, if you say, "Ki we are going," that's why we are not God.
Right.
Doctors are not God. We are just one person who can make a difference to your life if we get all the things.
Right, that answers the question, I think. Any more questions from the audience? Yes, please.
Just an observation. You're talking about AI, you're talking about predictiveness and improving upon the predictiveness. It will only improve when we have lots of data. And as recently pointed out by Dr. Srinath, we are different. But at the same time, sir, what you described at one of the instances of your targeted monoclonal therapy did not work because of the certain secretory thing which was there, and you came to know later. But at the same time, can this will be shared amongst all our other people? Do we have that kind of facility? Can't we have in the events like this or in the national conferences that this data sharing, this particular thing should be made a mandatory kind of thing to evolve ourselves? That is my only request, that it is high time that we leave our competition aside, we leave our commercial thing aside and come on a common platform, and dignitaries like you, luminary like you, think about having this collaboration, having the more data so that the AI will help us. That is my urge. Thank you.
Thank you. Yes, there.
Yeah, a very good afternoon to all of you. I'm a family physician, so coming to AI, technology, gadgets, monitors, all these things, I think most of the doctors have forgotten how to record blood pressure. When you go to a consultant, hardly no one records any blood pressure, no one sees pulse, No one examines physical examination whether there is icterus or anemia or anything. So everything on paper will not make a final decision. I follow this policy of personal interaction and personal physical examination, which is very, very important. I have seen in some ICUs monitors showing high blood pressure, but when you record, the blood pressure is normal in renal patients also. So these are very important things. Technology one side, but personal examination and giving. AI will not overtake the physicians. People will not live on AI. So it will just help us and it will guide us to do what we have to do. Thank you.
Right, thank you.
Sir, nice thought, sir. Only thing is, are you using any digital EMR in your office, in your thing? No. What will happen, so I understand that, but what it will help is, you will be able to follow up the patient's whole life.
No, that,
if you use a little bit of,
things.
yeah, that's all. So the other things are right.
Gadgets and technology and AI and other things, they will not give accurate things. Even a fundus examination, when you do it personally, it is different from what your machine says, sometimes.
Yeah, that is true. But what nobody is saying, I will, off the record, I will tell you some of the, when we meet off the, we will tell you some programs which will help you in identifying anemias of different type using AI with the same blood report, which we may not be aware of. Thank you.
Do we have any more questions? Anyone? Okay. Okay, then we will move on to felicitation of the panelists. May I kindly request our panelists be hand over the bouquets, please. One second. May I kindly request Mr. Riyad Matthew to kindly hand over the salvers to our panelists, please. Right. Dr. Sajan Nair, CEO, Zydus Hospital, Ahmedabad, please. Dr. B.S. Srinath, Managing Trustee, Sri Shankara Cancer Foundation, Bengaluru. Dr. Santosh Shetty, CEO, Kokilaben Hospitals, Mumbai. Dr. H. Sudarshan Balal, Chairman, Manipal Hospitals. Thank you so much, gentlemen, for a fantastic panel discussion and for your insights. Thank you once again. The panel discussion was indeed very, very insightful. I'm sure we all benefited from the insights shared by the panelists here today. May I now invite Dr. K.K. Verma from the AIIMS, All India Institute of Medical Sciences, to kindly share the insights with the gathering today. Thank you, sir. Please come.
Thank you. Very good afternoon to very eminent and the highly respected colleagues who have gathered here this morning. My name is Kaushal Verma. I am Dean at All India Institute of Medical Sciences, but I'm a dermatologist. I'm a professor of dermatology and I'm heading the Department of Dermatology. I'm so grateful to the week Malayalam Manorama group of publication for having invited us to be part of this illustrious gathering, and also I'm told chosen us as the best hospital in the country. I thank the leadership team of my hospital for choosing me to represent the AIIMS. And what I wanted just to briefly tell you what AIIMS is, I'm sure you all know. The AIIMS was a dream project of the first health minister of the country, Rajkumari Amrit Kaur. And this institution was established in 1956 through an act of parliament as an institution to provide the best of the medical education in the country, to produce the leadership where the people should get the best of the education and then they should disseminate across the country to establish the other medical colleges, the healthcare facilities. We were also interested with one second very important objective of doing the cutting edge research in the field of medicine and in the healthcare. And of course, since both these things, the medical education and research, it requires the patients. You can't do the medical research without patients. So obviously we got into the patients also. And the goal was to provide them the world-class treatment facilities also. This is a public funded hospital. So the care provided at AIIMS is almost completely free. No money is charged from the patients, unless you ask for the private room and look for the private facilities, then the charges are nominal. In terms of the medical education, we are the deemed university, which means we can decide our own curriculum, we can impart our own degrees, and now we have 56 departments at All India Institute of Medical Sciences, New Delhi. We have 8 super specialty centers, and we have over 1,300 faculty members as of now. Out of this, there would be about 700 professors. We have over 4,000 doctors who are managing this, the institution. Over 1,500 students. Students means they are the undergraduate level trainees, which includes MBBS students, the nursing students, the diplomas, the people come from the other kind of technology training in the field of medical education. And then we also take, say, the trainees from outside, from the other institutions who can come to the institute for short-term training. We call observership, which is varying from any time 2 weeks to as long as 6 months. And this is again on a very nominal charge. The institute has got over 25,000 employees who work around the clock for the hospital. So it's in a sense, city in a city. We have about 50,000 footfall at AIIMS every day, and over 12,000 vehicles, they will enter the campus. In terms of the research, all our departments and almost each faculty member is engaged into cutting edge research, and we do all kind of research, whether it is the basic research, the clinical research, the translational research, and we were talking about the AI. I think that is one of the important focus in our institution to work on the AI, because we need a lot of data to create for our own ethnicity, for our own people. and also the areas where the AI has a very dominant role, like we were talking about radio diagnosis. Dermatology is one of these. And then, of course, the other areas, other fields of medicine where we have very strongly started working. In terms of the research, as of now, we are running approximately very close to 1,000 research projects with a funding of over 200 crores. And the funding is primarily coming from, say, the government sources. The institution has got its own funding for the research. And then we have the funders coming from the other organizations like Indian Council of Medical Research, Department of Biotechnology, Department of Science and Technology, Council for Science and Industrial Research. Then we have the foreign collaboration with the other foreign universities. We get NIH grant. We are getting collaboration with the WHO. And then we have about 10 foreign universities who are collaborating with us in the area of medical education and also in the area of, say, the research and the technology transfer. We are also the #1 in medical research publications, bringing it about close to 12,000 publications every year. And we are second only to, if you talk about the total publications which are generating out of in the country, we are only second only to Indian Institute of Science, your institution in Bangalore, which is only doing research and they are not into, say, the teaching, they are not into, say, the patient care. But we are doing all three. The medical education is our primary goal, doing the research and then also providing the patient care. When we look at the patient care, we have close to 3,500 beds which are in the country, in the hospital. And then we have the centers also which has got the beds which are spread out. And as I said, that the treatment is world class. You talk about any machine, AIMS most likely will have it. And we have the experts. We have got the people trained on these machines within the country, outside country. And also, we had not just trained the faculty, the entire team gets trained when any of these machines come. And then we start using this. So I would like to thank the week once again for having chosen us and invited us. And like to thank you all for being here and being part of this. Thank you very much.
Thank you, sir. May I kindly invite Mr. Sumit Devasi, Senior Manager Circulation of the Week, to kindly hand over a memento. Sir, please join us on the stage for a felicitation, please. Mr. Devasi, please. Let's hear a loud round of applause, please. Thank you. Thank you. Thank you, sir. Right. May I kindly invite Dr. Govindaya Yatish, President, Private Hospitals and Nursing Homes Association of Karnataka, to kindly come over on the stage. And may I invite Mr. C.L.N. Prasad to kindly hand over the memento, the bouquet. Dr. Govindaya Yatish, please. Okay, I think he is a bit occupied outside. He'll join us in 2 minutes. Uh, on account of the World AIDS Day, ladies and gentlemen, unfortunately, Chief Minister and the Health Minister both have been occupied and with long drives towards Tumkur and Mysore respectively. And so we will now begin the awards for Best Hospitals Awards 2023. May I kindly request Mr. Riyad Matthew to come over onto the stage to kindly hand over the awards to all the winners for the Best Hospitals Awards 2023. We begin, and here are the names. Okay. Manipal Hospitals, HAL Airport Road, Best Multi-Specialty Private Hospital, Bengaluru. Please cheer. A big round of applause. Congratulations. Next we have Ruby Hall Clinic, Best Multi-Specialty Private Hospital in Pune. Please come over. Congratulations, Ruby Hall Clinic. Ruby Hall Clinic, Best Multi-Specialty Private Hospital in Pune. Someone who's representing Ruby Hall Clinic from Pune, please. Okay, so we will have the award sent across. We now move on to. We also had an award for Amrita Institute of Medical Sciences, Amrita Hospitals, for the Best Multi-Specialty Private Hospital in Cochin. We will have the award sent across to them as well. Next, we have KIMS Health, Best Multi-Specialty Private Hospital, Thiruvananthapuram. KIMS Health, Thiruvananthapuram, KIMS Health. Okay. Next, we have AMRI Hospitals, Best Multi-Specialty Private Hospital in Bhubaneswar. A big round of applause. Congratulations. That is congratulations there. We have Apollo Hospitals, Best Multi-Specialty Private Hospital in Chennai. Chennai, Apollo Hospitals in Chennai. Let the applause be continued. Zydus Hospitals, Best Multi-Specialty Private Hospital in Ahmedabad. Fortis Hospital, Mohali. Best multi-specialty private hospital, Chandigarh. Fortis Hospital, Mohali. Congratulations. Congratulations. Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Best Multi-Speciality Private Hospital in Mumbai. Indraprasth Apollo Hospitals, Best Multi-Speciality Private Hospital, Delhi. Indraprasth Apollo Hospitals, Delhi. Medanta, the Medcity, Gurugram. We will have this award sent across. Apollo Health City, Best Multi-Speciality Private Hospital, Hyderabad. Apollo Health City, Hyderabad. Choithram Hospital and Research Center, Best Multi-Speciality Private Hospital in Indore. Choithram Hospital and Research Center, Indore. Congratulations. Kovai Medical Center and Hospital, Best Multi-Speciality Private Hospital in Coimbatore. Kovai Medical Center and Hospital, Coimbatore. Apollo Multi-Speciality Hospitals, Best Multi-Speciality Private Hospital in Kolkata. Apollo Hospitals in Kolkata. Alexis Multi-Speciality Hospital, Best Multi-Speciality Private Hospital, Nagpur. Alexis Hospital in Nagpur. Congratulations. Please keep the applause coming, please. Apollo Hospitals Best Multi-Specialty Private Hospital, Bhubaneswar. Apollo Hospitals, Bhubaneswar. No. Yeah, that. Apollo Medics Super Speciality Hospitals, Best Multi Specialty Private Hospital, Lucknow. So there goes. Congratulations. Santokba Durlabji Memorial Hospital, Best Multi-Specialty Private Hospital in Jaipur. Santokba Durlabji Memorial Hospital, Jaipur. We now have the best multi-specialty hospitals all across India. All India Institute of Medical Sciences, Delhi. AIMS, Delhi. Of course. Now, zone-wise, we will have awards zone-wise. So, multi-specialty private hospitals, West Zone, goes to Kokilaben Dhirubhai Ambani Hospital and Medical Research Center, Mumbai. For the South Zone, we have Christian Medical College, Vellore. Please give a huge round of applause. For the East Zone, Apollo Multi-Specialty Hospitals, Kolkata. Gentlemen, I request you all to be on the stage because Apollo Hospitals Chennai has been awarded as the best multi-specialty hospitals listed. Hospitals that are listed, private listed. With that, we come to an end of the Best Hospitals Awards. May I request Mr. C. L. Prasad to come over onto the stage to hand over the bouquet to Dr. Govindaya Yatish, please. Congratulations. I now request Mr. Hari M. Warrior, Chief General Manager Sales, to kindly come onto the stage to address a vote of thanks, please.
I won't take too long. I know we are late for lunch, 5 minutes, but this is a very important part of the event. Like they say, gratitude is like wine for the soul, and on behalf of WEEK, I am here to actually deliver that wine. At the outset, let me thank each and every guest in this hall for your valuable presence this morning. WEEK has been actively engaged with the medical fraternity and shall always build on this trust partnership. We've always been publishing interesting stories from the medical fraternity, and we would like to continue with this association of ours. With respect to thanking our esteemed guests, let me first thank Dr. Manjunath for his excellent keynote speech on excellence and intelligent education. He also spoke about security infrastructure, and he shared so many numbers to us this morning, which actually baffled a lot of us. But these were really eyesights to us in terms of opportunities and gaps that are available today in society. We also had an expert speak on Anthony Prashant, and he was speaking on disruption. It took you like 20 years ahead, It was like coming out of a Steven Spielberg movie. We don't know what's going to happen to medicine and engineering once they both get together. Very interesting, and it also gave us a reassurance that we are in safe hands even with AI in medicine. The panel discussion was excellent, very vibrant, and an intelligent topic also for discussion, where we also understood that engineering has adopted, or medicine has adopted engineering in a very smooth manner. This was very interesting for us also, because we are all laymen in both these professions. We only know everything about media. So thank you once again to each one of you. I must also thank the host of this city, Manipal Hospitals, for actively helping us to put this entire event together. Once again, thank you from the WEEK and Malayalam Manorama. Thank you.
May I request Mr. Riyad Matthew to please join us on the stage to give an award. We announced the award, but the representative wasn't around here, and so that is why we will announce the award again. This goes to KIMS Health, Best Multi-Specialty Private Hospital, Thiruvananthapuram. Please. Thank you and congratulations. So with this, we come to an end of the program. Ladies and gentlemen, please join us for lunch. And also, before you leave, you have to take with you the boxes that are kept here, the salvos that are kept here. So please do not go without them. Thank you. Enjoy.